Hello, everybody. Welcome. So glad to see you. Chelsea and Heidi are being very brave. They're in video. We're very excited to see you. And Giovanni. Oh, Giovanni, you're on the treadmill again. You feel horrible. Okay. So welcome, everybody. I'm impressed with the number of people we have at 5 p.m. Eastern on a Friday. Dr. Harris and I are here, and we're going to talk to you about something that we're both pretty passionate about. It's actually something that sort of brought us together many moons ago. We will, if you're not presenting, you can come off video, and we'll take over the video part. When we do question and answer, we'd love to see your faces again. I'm going to go ahead and share my screen and bring up maybe a presentation. I will warn you, Dr. Harris and I are kind of winging this, and it is a passion, and we will do our best for you. We didn't have much time to talk about what we were going to do. So for those of you who don't know, my name is Dr. L.A. Stretch. I am the department chair for the Clinical Mental Health Counseling Program. And a little background and my connection to the Virtual Clinical Training Center is that when I was hired to join the Chicago School and build this program, my one condition was that I be allowed to develop a virtual clinical training center. I had been at a couple of other institutions and tried to get this off the ground and had met with a lot of, it can't be done, it'll never work, it's impossible. And when I came to the Chicago School, they were like, we can't wait, let's do it. When do you want to start? And it was just so refreshing to be in an institution that truly meets the things up here in the upper right-hand corner, that they're focused on education, innovation, service, and community. And the Virtual Clinical Training Center captures all four parts of our mission. We're educating new professionals, we're utilizing innovation, and we're serving underserved communities who aren't getting the services they need to be healthy with health. And so I'm really excited that we're able to really fulfill the Chicago school system through this. Dr. Foster, unfortunately, can't be with us today. She has something else, but she sends her regards, and she's a very active part of this team. And Dr. Harris, I'll give you a few minutes to introduce yourself.
Yes, of course. So I am, for you guys to know, I'm Dr. Rodney Harris, and actually I've known Dr. L.A. for a number of years, and we met putting together a supervision workshop a number of years ago. And so when I came to the Chicago School, that was one of a seed that she planted in the back of my mind, that was something that she was looking at getting started. And when that was something that she wanted me to start working on. And that was when she hired me, she said, this is what we're going to do. And immediately after I came on, she was like, here's my vision, and I want you to run with it. And so that was how a couple months later, a year later, here we are. So that's how it came into fruition.
Great. Yep. So we're hoping that by the time this session finishes, that you will know why is learning telebehavioral health so important. How does the VCTC work? What are the components? And then how do you get involved with the VCTC if you want to? And Rodney, if I step on your toes on any of the slides, just cut me off. Telebehavioral health is the official term for telehealth in the mental health field right now. It is the practice of behavioral health using telecommunication systems to exchange information. Now, up until a few years ago, I really believed this part of the definition that said that it was at geographically separate sites. But then I encountered the millennials and found out that they can bring telecommunications right into the room with you. I was running an adolescent dialectical behavioral group for a friend, and while I was in the group session, one of the clients who had my work number texted me while we were in a group session. And it was kind of humorous, but I redirected her to talk to the group. But at that moment, we were simultaneously doing in-person and telebehavioral health in the same room, breathing the same air. So it doesn't really have to happen in geographically separate areas. It can be people in the same room using some form of telecommunication. most of the time, telebehavioral health is in real-time telecommunications. And when we talk about real time, we're talking about an exchange. Like right now, as I'm talking, you're hearing me within nanoseconds. Same thing. Dr. Harris, if he talks, you're seeing and hearing us in, almost instantaneously. And that's what we call synchronous or real-time exchange. There's also store and forward, which is asynchronous exchanges. That could be things like email, for example, where I write an email, I store it, I send it, computer holds on to it till you're ready to read it, you review it, you respond to it, and then it forwards and sends to me. And it's an asynchronous exchange. Both of these types of exchanges are covered by law. Both of these exchanges, synchronous and asynchronous in telebehavioral health, are covered by our codes of ethics. Now, the one thing I will say that's not mentioned on this slide that I do want to stress is that there is no single code of ethics that fully informs us about how to do this appropriately. Telebehavioral health is an area that must absolutely be handled from an integrative mental health approach, even an integrative medical approach. Because the ACA code, though we have Section H of the code, which really informs us about how to interact online with our clients and supervisees, it does not give us everything we need. And I utilize multiple codes, the National Association of Drug and Alcohol Counselors, the Association of Social Work, the LMFTs, the Marriage and Family, AMFT, and the APA codes. I use all 5 of those codes to inform my work as a telebehavioral counselor and a supervisor. So it's really important to understand that we need to understand telehealth, because if you're talking to clients by phone, you're engaged in telebehavioral health. If you're talking to clients by chat or text or email, you're engaged in telebehavioral health. I am a firm believer at this point in our profession that this has become an essential course, an essential knowledge. In fact, KCREP, the Council for Accreditation of Counseling-Related Education Programs, has now integrated 8 standards into the 2016 code standards that says we have a responsibility to teach you about technology. This is something that is so important, it needs to become an integral part of any of the counseling programs. So 5 reasons for telebehavioral health. It's a minimal contact healthcare. We don't have to touch our clients, nor should we be, in order to engage them and help them. I will tell you this, though, that for my own children, I actually use an online medical service through the Chicago School to get support when they're sick. If I don't want to take them to the doctor's office and get them sicker, I can actually meet with a nurse practitioner, pediatrician online who can diagnose and even prescribe for my children without ever laying a hand on them, which I think is just amazing that we've come to that level. So it's really integrative healthcare. There's a growing number of payers. When we talk about payers, we're talking about insurance, Medicaid, even private providers that are paying and reimbursing for telehealth because they're recognizing the efficacy and the efficiency of it. It also reduces the stigma of being in a mental health practitioner's office, right? If you park outside my office, especially in a town as big as what I live in, everybody's going to know that you were at Dr. LA's office or Dr. Brown's office or Dr. Harris's office. So it's really important that people have that confidentiality and that they want to maybe not let the world know that they're seeing a counselor. There's also more and more incentives, even at the state level and national level, to engage in these innovative solutions. I was involved a few years ago in a grant to provide reintegration services for military families. I live very close to Fayetteville, which has got a couple of large bases there, Pope and Bragg. And when we were working with a large influx back from Iraq and Afghanistan and other areas, the military was actually engaging with private practitioners to be able to provide services, to begin the reintegration services with families prior to their arrival back in the States. And that was a really rewarding program to be part of. And also, patients love it. Clients love it. They love the convenience of it, and they love being able to interact, and they're being helped and healed, which is important to know as well. Now, as I mentioned, we really have to approach telehealth from a very comprehensive ethical standards, and we can't just use ACA. I actually did, and I'm hoping to publish soon, a qualitative research study of the 5 major mental health as Dr. TRW calls them, sisters, mental health sisters. And I looked at the 5 major codes to identify what are the themes, what are the things that we have to know in order to practice ethically and legally in telebehavioral health. And I came up with these 14 areas. So each one of these areas is critical to understanding how to practice ethically and legally in telebehavioral health. This is above and beyond everything you need to know related to counseling that you do with the person in front of you. So in-ground counseling plus all of these additional standards that are specific to telebehavioral health. So you can see that with this much information that you need to understand that's specific to telehealth, it would require additional training and support. Dr. Harris. Are you on mute?
Yes, I was. Yeah, I was on mute. I was actually in the chat room too. So I was on mute, and I was also in the chat room responding to a couple of questions. So, in talking about disclosures, I also thought about telehealth, the importance of it. And I was thinking about one of the first times when my wife, as a first-time mommy, when she would go to the doctor. And what she did is she would go repeatedly. So one of the things they did, and I would say, sweetheart, if you keep going, they're going to think that something is wrong. And they said, I think you're going too much. And so what they did is they actually gave her a referral to the nurse. And they would say, okay, instead of coming to us so much, what we want you to do is we want you to call this nurse. And so she was like, I'm not going to that nurse. I'm going to keep going to see the regular doctor. I want to see someone face to face. And so what they did is eventually told her, no, we want you to eventually. And so what they did is they wanted to encourage the use of her to use telehealth as an option. And so as far as the integrated model that they were pushing for her, and so as far as the first use of that integrated model that I saw a couple of years back, probably 8 to 10 years ago, was the push for that, and an integrated model was then. And so I just kind of wanted to mention that, and that was some of what we were talking about in the chat room. Mm-hmm. So some disclosures that are real important. It's really important that you verify the identity of the client. That would also determine if the client is a minor. And in addition to that we want it's really important that we explain the procedures for contacting the client when the person is offline. So what do we do if, in cases of an emergency, what do we do if we're not here, if something comes up? You want to have policies and procedures, and you want to have that in your disclosure statement. And what do you do in case Blue Jeans fails? What do you want to do in case something happens to the technology? What are some alternative means for us to communicate? And that's really important that you have some means to cope with that you have a backup policy for that. And how do you cope with potential misunderstanding when visual cues do not exist? So in case how do you deal with that? And then that you identify an appropriately trained professional who can provide local assistance. So in case there's a crisis and you need that you have someone that's on ground that you can deal with, that person that can provide crisis intervention, and that you have a name, a contact person, and you will be able to reach that person, and that you can go out and you have that person's name in that disclosure. So that's really important part of, and that's to protect you. We do address that. In addition to that, you talk about encryption methods used to help ensure the security of the communication. Now that's really important. I know Dr. L.A. In some of her previous workshops and previous articles has lots of information that she's talked about, the encryption methods and the importance of security of communication. So lots of readings and materials that are out about that. That's really important for you to talk about the security of that, particularly as you look at texting and security of, you just can't text. And also in addition to communication online, you really got to be careful with emails that and even with what Skype and that you're using a secure modality as far as your communication. You just can't just talk on every medium. That you're aware of the hazards of unsecure communication. That's kind of what I just talked about just then. and then that your data is preserved and what manner and how long. And then also you talk about what procedures are in place for receiving and releasing client information through the internet and other electronic sources.
So we're going to tag team this one, but you know, the whole purpose of the VCTC, well, there's two purposes to the VCTC. It's really a two-tiered process. And when we created the mission of the Virtual Clinical Training Center, we really wanted to embrace that integrated telebehavioral health approach. The goal was to be able to create or connect clinicians in training with clients in need. And that was really the goal, is to try to bring those two populations together so that they could help each other and then tap into the expertise of the faculty supervisors to supervise that whole process. Rodney, you want to add? Talk to the rest?
Yeah, and we also wanted to, as far as having this team of expert clinicians, as far as the staff that we have, and be able to offer the support in our staff, that we have this realm of staff that have all this expertise in this field. And so we have diversity of staff, and that we will be able to offer support not only to our clinicians, but to the university community and also to the community at large. And so we have all this wealth of experience that, you know, we will be able to offer our learners in the community at large.
Yeah. So you can see some of the things that we were really striving when we created the VCTC, when we wanted to have well-rounded counseling services, individual, couple, groups, family. We wanted to be evidence-based. We also wanted to be outcome-driven. And this is really Dr. Foster's her expertise, where she's really helped us create outcome measures and really track and report out on program evaluation tools to make sure that what we're doing is efficacious, that it is working, that it is helping not only the clients, but also is helping the students become better practitioners. And, you know, one of the requirements that we have, and we are one of just a couple of institutions right now that are offering this course in the whole country, is we have a telebehavioral health course. Sure, there are universities that offer seminars and they offer little components within their course, but we're one of the first in the whole country that offered telebehavioral health as a 3-credit elective course. I'd make it a core if I could, but I haven't been able to get there yet. Telebehavioral health training for our, like as Dr. Harris said, for the staff and for the consumers, but also being that resource for the community and providing things like this. You know, we've invited our partners, our site supervisors, and our community partners to be part of this conference. This is a great example of utilizing technology to disseminate information. And you, Dr. Harris?
Yeah, and so as we look at how does the center work, and looking at the chart, so there are a couple of different components as you kind of look at it. Number one is we look at, there's a branch, we have the career services, and those are some internal partnerships that we have with career services. And through career services, we offer individual, group, and psychoeducational services. And that was a partnership that we formed a couple of years ago. And actually, Dr. Foster and Dr. LA kind of facilitated that partnership. And
well, I need to give credit to Colleen Malone.
Malone, actually, yeah, you know what? Let me take that back. You're right. Actually, we got to get that, Colleen. Yeah, Colleen facilitated that. And then in addition to that, we have the program facilitation groups. And that's from the program support, and that's development and skill-based group facilitation model. And we'll talk a little bit more about that on the next slide. And then we have the Born Free Clinic, and that's an external partnership. And Cape Freer Clinic is an external partnership. And then particularly with the Born Free model, that's a model that provides client-centered mental health and substance abuse services. And it's a model that provides, and then with the Cape Fear model, that's a client-centered mental health services model. Okay, yeah.
One of the things, and Cape Fear unfortunately lost a lot of their staff due to defunding with the current administration. So we haven't been able to develop that particular partnership as much as I would like, but I was actually talking to their director just yesterday, and they are really interested in trying to figure out how to make it work with their new staffing. And we're hopefully going to be able to do it, because one of the things I really like about the Cape Fear Clinic is it's also a medical clinic and a dental clinic. And so it really captures that integrative health model that we were talking about. And they're in Wilmington, North Carolina, and that community has been absolutely devastated by the last hurricane. And it looks like a war zone down there. It really does. And they just were able to open up some of the major roads 3 weeks after the hurricane. So that's a community that's really in need. So I'm hoping that we might be able to really build in that community. And we've got a couple of other partnerships, Dr. Harris, that are in development. One is right with the Indiana homeless shelter in Indiana, and then also with a counseling center in Indiana. So those are promising and hopeful, possible expansions.
Mm-hmm. Mm-hmm.
Okay. So with the career development, this particular part of the VCTC is really one of the ways that we can really give back to the Chicago School. We have one person that's in our Career Center who's managing this whole process. And one of the things that the Career Center had not been able to offer really was individualized services, psychoeducational groups, career outreach and assessment. And so thanks to Colleen, we reached out to the director of the Career Center and really started to have some conversations about, hey, our students have this unique set. Of all the programs at the Chicago School, our students are the only students that are truly trained in career counseling. They have a whole course on career counseling. They have a course on assessment. Like, our students are ready to go. They can help with these services. So in spring 2018, we launched our individual services. In spring 2, we launched the group services, and we started the psychoeducational groups in spring 1. And you can see the different types of things here on the slide that the team does. I mean, mock interviews, mastering setting goals, reality and balancing school life. We've all had to deal with that. And even assessment of career materials, to help people figure out, what do I want to do and how do I want to do it? And then in group services, some of the group services we've offered is just, support. And our undergraduate BA program, we've worked with closely to develop, support for those students and trying to figure out what's next. What am I going to do after this? Looking at what's it like to be a new graduate student. And then with psychoeducational groups, you can see some of the titles of some of the groups that have run in the spring as well. These really have given our students an opportunity to really showcase their expertise and things that they've learned and things that they've mastered in their own time as graduate students. And I think that it's been just an amazing partnership that we've been able to just give back to the Chicago School and really serve future students. And this one's yours, okay?
Yeah. And so one of my probably favorite parts of the VCTC are the facilitation groups. And these have grown rapidly. And actually, we probably started with 1 or 2, and now I think we have 10, 3, 4, 5, 6, 7, 8. Yeah, we have 10.
Actually, we're running 20 total across all the courses.
Yeah.
Yeah, it's a lot.
Yeah, it's a lot. And one of the learnings, one of the learnings that we've developed from these is that these groups, and the feedback that we've gotten from these groups is that the students, the learners actually love these groups, and they love receiving, they love learning from other learners. And so we have, we started with 1, and because of feedback that we received, we rapidly started to work with Dr. E, and she would ask us about, what are your thoughts about this? And then we would expand up, and she would ask us for feedback, and we would start with another one. And so we ended up starting with 1, and then we would open it up, and we would start with another one. And so they have rapidly grown. And then just recently, we opened the Practice Skills Lab. That was probably one of the last ones that we ended up opening. And so that's kind of how we ended up with rapidly growing all of these. And so they are, and occasionally with some of these are co-facilitated. Some of them will end up being co-facilitated, because sometimes what will happen is, as a skills-based teaching, particularly some of them I have, and sometimes we will, I will go inside with them and I will co-facilitate with them.
Mm-hmm. I'm wondering if we've had are there any students on the call right now who have helped facilitate any
Let's
of
see.
these?
I'm here. I just started VCTC this semester, but
And who is this? I'm sorry, I can't see the chat. So.
This is Katie Kesterson.
Oh, hey.
Oh.
Hi. So yeah, I just started this semester, and as somebody facilitating, I would say as rewarding as you guys describe it to be for the students being facilitated, it's just as rewarding facilitating it. It's such a different perspective, and it's such a great perspective. And it not only assists, the people being facilitated with getting a different kind of knowledge from it, but I find myself also learning from the people who are in it different ways of thinking that I may otherwise not gain.
Yeah. Katie, can you share kind of what the structure of one of these might look like for somebody who might not be familiar? I mean, most people have experienced the 500, but some haven't because we just started that one. So just kind of what's a typical lab look like?
Sure. So we are provided with like a basic structure, and I would say it's very conversational in nature, and it's also, as a facilitator, you're kind of guiding that into the goals of the class for which you're facilitating. So depending on what the class is, like in 500, we talked about SMART goals, and then we did some case assessment, and then we still have another one for that one, looking at something different. So that one is a little bit more, the topics kind of range in that one, whereas if you look at diagnostic skills, we're looking at the same case over 3 weeks and assessing that case, and the students get to work together, and we just kind of assist in that facilitation.
Mm-hmm. Katie, thank you. That was an awesome addition. I really appreciate it.
No problem.
Yeah, and what about anybody who might be on the call who's been on the receiving end of this? What was this like for you? And Dr. Harris, you may need to call somebody out, but I think if we can get somebody who will volunteer who's been in one of these lab groups and has benefited
I'm looking
from
on my list to see who I might know up here. Okay. Hey, let me see. Now, I know one person up here. I don't want to have to call her out because she's going to get mad with me. Me and her had a run in. My good friend, Shanta, are you going to talk with me? Are you going to tell her what it was like being in those groups? She's my good friend.
How I knew you was going to pick me. And I was kind of laying low, like, okay.
Yeah.
I kind of missed the beginning of the question. Was it, how did those labs work out?
Yeah.
As the lab, what was that like, and did you get anything from it? I guess that's the question.
For me, I did part of my undergrad online, and I struggled with it. And then in CM 500, I did the certificate program when I came here, and everything was online. But when I got into CM 500 and we had those labs with Donna, I thought Blue Jean was the best thing ever, because I was like, because it's great to write a paper or see something on the computer, but to be able to talk to somebody and hear another view or someone to talk back to you, I always say any lab I'm in, I think it's the best. To me, when we do live labs or discussion questions, it's just a better feeling to be able to talk, because you're online, but you still get the face-to-face time. So I personally love the lab sessions and the facilitators that Donna, and then it's even better when it's a student that's kind of ahead of you in the program, because it's like, it's not a professor that's so far in their career, it's someone that's kind of just got where you're going, it makes it a little bit easier to get it from them.
Right.
So I personally like it.
Well, and one of the things that I really like about this, and I have to really give kudos to Dr. Harris and Dr. Foster and the students who are doing, and even the students who are participating, because we're very serious about program evaluation in our program. We take the feedback you give us and we try to make it better. So, for example, I'm looking at Dr. Foster's program evaluation report for this past year. And when we first launched the CM571, which is the Counseling Assessment Skills Lab, we had about 80% of the students reporting it was somewhat helpful to helpful. That's not a bad number. That's a pretty good number, right? But Dr. Harris and Dr. Foster and the students went back to the drawing board and said, we want it better. We want more students to benefit from this. We want this to be better than what we did. And the next time they ran those labs with the changes they had made, they had 90% of the students report that it was helpful or somewhat helpful. And 60% were very helpful and 30% were somewhat helpful. And that's a big jump to go from one run to the next run to see a 10% increase in satisfaction and like finding it helpful. And then, 7% were neutral and 7 were unhelpful. And, I'm always going to expect that there's going to be up to a 10% it wasn't helpful. And there's lots of reasons for that. But Dr. Foster and then collect information even on that small percentage to find out what could we have done to help that one group, that one or two students feel more connected to that experience. So Shanta, I really appreciate you sharing and telling us about your experience. Dr. Harris, is there anybody else we should ask about their experience that's on the chat? Because I can't see the participant list of the chat.
Does anybody else want to share before I go through the names? Because I know I see a couple other people up there. Dr. LA, I wanted to share, that point about, because I think the original intent, we weren't, when we started out, I think it was maybe like 1 or 2 courses. Our intent wasn't to grow into 10 courses. We were just experimenting to do it with 1 or 2 courses. And I think, what you said about, being data driven and, really listening to the learners, really paying attention to what they were saying and receiving the feedback and the enthusiasm that they had around the courses, it kind of made us excited about their learning. And I think, I think our enthusiasm about the discussion groups, and I know myself, I really love the discussion groups. I know that's what attracted me to the Chicago school. That's what, it made it learning live. It made it learning the dynamic. It made it interesting for me. And to see the excitement and enthusiasm, the passion around that, that's what made it grow from 1 to 20, so fast. And that dynamic, that momentum is, I think, what builds it, what causes it to grow, what causes us to go back and, consult with Dr. E and Dr. Foster and, go back and talk with you and Dr. TRW. And I think that's what kind of builds it and makes it into what it's grown into. And I don't think we imagined that it would grow into this, because being transparent, this occurred through like a Sunday conversation with myself and Dr. Foster, because we were trying to figure out how to make the lab grow, and with her, we were trying to figure out, she was telling me what she was going to cook on Sunday. And then we emailed Dr. LA, and, just being the kind of the visionary leader that she is, she trusts us to say, I trust you guys, go with it, run with it. I like it. I trust you to, that this is going to go. And she said, okay, go with it. And that's what we did. And that's kind of how it came into this. So like, this wasn't an original part of the proposal. This wasn't like, what we wrote down as an original part of the vision. This came about on a Sunday evening at dinner with a conversation with me and Dr. Foster, talking about data or something else,
Right, so. Exactly. So it's very organic. We are looking the VCTC to be very organic to the needs and the desires of our students and the faculty. What do you want this to be? We want this to be your VCTC. Like, if there's something you see that you think this could become, or if you know of an agency that might be interested in partnering,
Yeah.
most of the agencies that we've connected with have been through
Yes.
student contacts or people who have had their internships at places who now say, hey, I think they'd be a great VCTC program, part of our program. And now we're developing those relationships. So it's been just amazing how this has grown so quickly. And let me tell you a little bit about the external partnerships, just a little bit more. Born Free Clinic is a national model for opioid treatment. And they have staff that were providing substance abuse counseling, but who really couldn't address the co-occurring mental illness and the mental issues that were going on. And really the goal was to implement this holistic well-being client. And then, like I said, with Cape Fear, they're a charitable clinic. They're actually an HIV clinic, free clinic, provide tremendous support and services to their community. Clients pay little or nothing for the services they receive at the Cape Fear Clinic. Cape Fear Clinic's been in Wilmington now for 30 years. And so it's a huge community resource, but has been really just gutted by the current administration as far as grants not being refunded, and have lost over half of their staff, which is a very sad sight. But they're hanging on and they're doing the best they can. And some of the things that we've learned, because like with any new initiative, you have grand plans, but you've learned, right, is that people don't always or cannot always deliver on what they said. So these partnerships haven't always gone as smoothly as we'd want them to, but we've learned a lot of lessons. And from these lessons of, people not getting maybe as much supervision as we expected them to, or maybe they said they were going to have this many clients, they didn't have this many clients, right? That we've learned a lot of lessons that we're now really rolling into these new partnerships that we're dealing with. And Dr. Harris and Dr. Foster have really been able to shore up our procedures and our policies and our guidelines. And we're being more and more selective about the sites that we're partnering with, because we want to ensure that they're able to provide us with the services that our students need and deserve. So it's been a learning process. Dr. Harris, did you want to add anything to that?
I will, yeah. One thing I will say, I was actually in the chat room again too. I will tell you, about these external partnerships. I am excited about those, but I am on fire about the new ones that we're currently about to partner with, and primarily because those are the ones that have been student-led, and those are former students that understand how VCTC works. They understand it, and so they are. So they have some enthusiasm about VCTC, and they are pushing it from the inside. And so, particularly about this homeless program and the model that we're building, and because we have some support from the inside. And so I think as soon as we iron out the contract for that, that is going to be awesome.
Yeah, I agree. So this is just some initial program data about the number of hours that have been offered, the number of lab hours, and this is from fall 2017, or since fall 2017 to actually this went through, I think spring too. I don't think this includes summer data. So just know that is, a little bit more dated data, but we've had a lot more outcome since then that we can always talk about if people are interested. But I really love the data collection process and analysis process that they've developed with the VCTC, because we're getting quantitative research not only from the receivers of services, but we're also getting data from the facilitators of service. So we're getting it from both sides, and from the site supervisors and university supervisors. We're also getting qualitative data. So it's a very rich data set that helps inform the changes we're making, the improvements we're making, and the progress we're making towards, VCTC potentially even one day being an independent agency within the Chicago School. So it's something that may happen. But just overall, just excited with the growth and how we've learned from our lessons. So I'll leave this last part with you, Dr. Harris.
hmm So, as far as steps for applying to the VCTC, you successfully complete CM 597. That's the telebehavioral course with a B plus or higher. And then after that, you meet with the director of clinical training to determine how many slots we have available for the program. And right now, that's with Dr. Soley. And then after you do that, you'll complete a VCTC application. And then after you complete the application, you'll interview with the director of the Virtual Clinical Training Center, the directors. And right now, that's Dr. Foster or myself. And and then one of the reasons that we do that is because one of the things we really recognize is this program and the schedule is not for everyone because of the unique populations that sometimes we work with, and particularly with the Born Free Clinic. And I will tell anyone, I am not a morning person. And for the Born Free Clinic, it is a 5 o'clock, like a 5 o'clock to 11. And so if I had to get up at 5 o'clock, I'm not a smiley, cheery person at 5 o'clock. And so working with that population at 5 o'clock in the morning, I probably wouldn't be, I'm not the ideal person to work there. And so, if you are a morning person and can get up and do that, then, great. And so, we tell people, if you can do it, wake up at 4, get there and be motivated and cheery and, then great, that might be for you. But if not, then, we'll find somewhere else for you, but that might not. And then the other thing is working with substance abuse, that is your unique population and it's your unique skill set. And if you don't have the skill set to work with that population, then, or if there's something in your history, or if that's a population that you don't enjoy working with, then, we let you know, then this is not the population for you. And we recognize that as something that we've learned that, this may not be the population for you, and we'll find something else for you.
Yeah. And I would say, too, that, just to clarify for everybody, because not everybody may know, is the VCTC, the Virtual Clinical Training Center, is a practicum site option for students. So you can apply to do it during your practicum. You can do up to 50% of your internship at the VCTC, but we do need you to do at least 50% of your internship with on-ground clients, because we need to train you and make sure you're a well-rounded counselor and make sure you have experiences in both. So that is something really important to remember as you're thinking about if you want to participate in the VCTC. And as we mentioned, the CM 597 course is an elective course. It's offered the second term of every term. It's usually taught by either Dr. Harris, Dr. TRW, or myself. And it's a class that I love to teach when they let me teach. But it's a really informative class. I mean, it is packed full of information, and it's a class that I think really gives you an opportunity to not only learn about telebehavioral health, but we also give you some opportunities to engage or practice what it might be like through some live discussion. Katie, do you remember anything you want to say about the class? I believe you took the class, so I know you took the class actually.
Yeah. I mean, I would just encourage any and everyone to take it, because even for those that feel like VCTC wouldn't be an option for them, I feel like the field is really moving in this direction. And, beyond just the telebehavioral health information that you learn, it also applies to, meeting clients face to face on site as well. And just, it really makes you think about, specifically the safety of a client and verifying their identity, and how important body language is, and how to recognize that, through a camera in a limited scope. And, that just all makes you so much more proficient in recognizing those nonverbal skills when you have somebody then in front of you in person. So I think that's a very powerful part of the course.
And Katie, do you remember the creative assignment about coming up with a creative intervention?
I do not offhand.
Okay, so one of our live discussions in that class is one of my favorite assignments across the whole curriculum. And that is we ask students to come up with an experiential creative intervention they could do with clients while they're engaged in telebehavioral health. Because one of the things I found as I've been training people all over the world in telebehavioral health is they think, well, I'm in this camera, so all I can do is talk therapy. And I couldn't just do talk therapy. It wouldn't work for me. I'm very experiential, creative, art, music, yoga type person. And so one of the assignments, as I mentioned, is we ask these, ask the students to bring, and it has been absolutely amazing what students have come up with. Of course, people bring in music therapy and art therapy, but one of the students brought in the idea of teaching veterans how to knit as an anxiety reducer. It was evidence-based. She had evidence. She also thought about how she would need 2 cameras and how that would work so she could show them how to do the moves as they were in session. It was just amazing. It was just such a great example of how to use technology, not to limit, but to expand your access to clients and reaching clients, that you can still do. The modality doesn't have to inform the type of counseling you do. You can do just about anything. I have figured out how to do sand play, art therapy, yoga. I've got about all sorts of things, breathing exercises I do with my clients that really brings that experiential experience in. So telebehavioral health doesn't have to limit you. It should give an expansion of what you're able to do and access. Okay. So I'm going to come out of the presentation, and now we're going to open it up for questions, comments, thoughts.
I wanted to make a. Go ahead.
Sorry, I was just going to piggyback off of something that Katie was saying about recommending the class to everyone. As someone who has not taken the class, I had a lot of electives for the states that I want to get licensed in. So I opted not to take the course and do my field work in at a real site, I guess. I don't know how would I say that anyway. And I have wished that I had taken it day one of fieldwork, because number one, I had some situations arise in which I'm having to play catch up learning these things because I did not take the course, but I have the opportunity to do telebehavioral health with some of my clients. I also recognize that technology is a part of our daily lives now across every aspect of our lives, and I feel like in order to be on the cutting edge of our field, we need to know how to do these things. So
yeah,
I wish that I had taken it, and I am playing catch up now. So if you have the opportunity to take it as an elective, I am with Katie, and I recommend it 100%.
Thank you, Ivy. Well said. And I wanted to touch on Tiffany Rush Wilson posted, and I want to make sure everybody knows, because there used to be a credential called the DCC, the Distance Credentialed Counselor, and Dr. Rush Wilson, Dr. Soley, Rodney, all of us had that credential, and we are actually either have switched over or all switching over now. I have 20 minutes of recording to watch and a test to take. The board certified telemental health provider. And so you're going to start seeing those letters of VCTMH behind several of your faculty members who are completing that new board certified process so that we can have that credential. Because it is something, we are really, I go to universities all around the world in my job, because I have another position with KCREP as the IRSEP manager, and I talk to universities around the world. And I also do KCREP site visits all over the country. And I go into these universities that have absolutely no idea how to approach telehealth, how to teach it, where they need to start, because they've never learned it themselves. Many of the faculty have just never had courses or training in it themselves, and so they're at a loss. Over half your faculty are telemental health providers. We have such a very rich faculty when it comes to the knowledge base and the experience in this particular field. In fact, I'd like to invite Dr. Rush Wilson. Can you speak to some of like an experience or share something, because you're so very talented in this area as well?
Speak to an experience with a client?
Mhm.
Yeah, just like what's it been like for you to integrate telebehavioral health into your practice as a clinician?
Well, it's been interesting because my practice is in Ohio, and 5 days out of the week I live in Toronto. So because of the way Ohio's law is set up, and I did have to call to make sure, the therapist or the counselor or the social worker, whoever that person is, does not have to be present, just licensed in that state, but the client must be within one of the 88 counties in the state of Ohio. So I see my clients when I'm in Ohio those 2 days a week, and then there's sometimes a person wants to be seen Wednesday at 7:15 or something like that. I'm able to do that and still see that person, meet e-face to e-face is what we call it, and still see their facial expressions, tone of voice, see the background where they are, and actually am invited in some ways into their space. So for instance, one client has started painting, which is something I like to do sometimes too. She can show me her paintings without having to lug a canvas up to the practice when I am there in Ohio on weekends. So it's been really rich to be able to see people in their space, and then also in the office space can see the difference, see the similarities, be at, I don't want to say beck and call, but be able to make quick, immediate appointments. It's convenient. It's impressive. It's important.
Yeah. And I found it to be really effective, like I said, with military families. Military families are just really receptive. They're used to managing and having relationships at a distance. And for me being in Eastern Carolina, and Dr. Harris as well, we are just surrounded by the military. Every branch has 1 to 2 facilities in Eastern Carolina. Most of our state is military. And it's just been a huge bonus to being able to maintain those family connections and continue services even when they're deployed. So that's been a big benefit for me as well. Any other comments, questions, thoughts?
One quick comment, it's not really about telebehavioral health, but it's related in a little way. There's also an organization called Give an Hour. Are you familiar with them?
Yes. Mm-hmm.
Yeah. And I'm able to donate an hour, it's usually more than an hour, but an hour to military families, and I can see them either via telebehavioral health or in office when they're there. So that's something else that you may want to think about if military families is an interest of yours.
And Desiree asked a really good question about where the client resides. You actually have to know where the clinician is and the client. So Dr. Harris and I reside in North Carolina, and in North Carolina, you have to be licensed where the clinician is located and where the client resides. Kansas is the same way. But you have to check every state. As you heard Dr. Rush Wilson say, in Ohio, her and Dr. Hudson, they just have to have their client be in Ohio, whereas, they could be anywhere else in the world. So you need to check each state. And it's also true that, I'm licensed by North Carolina. North Carolina only has the ability to license me within the boundaries of North Carolina. So that doesn't give me the right to see clients in South Carolina, Kentucky, Tennessee, Virginia, anywhere. I only have the right to see clients within the boundaries of North Carolina. If I want to see clients in other states, I have to get licensed in those other states to be able to provide services. And you have to know the residence laws, because like in Florida, if you go to Florida for 2 weeks, on day 14, you've officially become a Floridian. And you have to know, when does the person actually become a resident. So these are some of the layers of complication that happen when you're engaging in telehealth, and you really have to really be willing to do the research and engage ethically and legally so that you can do this in the right way. Mm-hmm. Other questions, thoughts, comments from anybody?
This is a comment, and it's really about keeping your pulse on the profession and how the profession is changing. And so when supervision was kind of first came out, actually, Dr. L.A., I think that was when we first kind of crossed paths. And so supervision was like the thing. And so it was like race, supervision. A number of years later, our paths crossed again. And it was like right when distance was just kind of distance education, distance learning, telebehavior. It was coming, kind of just becoming, the pulse was changing. And so right then you were at a on Ground University, and I was going to start my PhD. And one of the things you told me is you said, no. And you said you should consider, doing online. And I said, and, I didn't say it to you, but I thought it's
that I lost my mind.
Yeah, just like probably everybody else in the profession. I say she has gone cuckoo, you know, and then later on I started embracing it. And so fast forward, as far as being on the pulse of the profession and the way the profession is moving, look at now. If I would have missed kind of the wave and how the profession was moving, I would not have been here. And how the distance learning and how telebehavioral health and how it's impacting and moving the profession totally in a new direction. And for my peers that didn't embrace that. And so I challenge you to, keep your ear to the pulse of how education and how counseling is training is changing. And, be aware of when you go to conferences, be aware of, what is relevant, what's changing. And, when you go to, just see what's out there and pay attention. That's really going to help you grow. That's really what's going to change. And what may sound foreign and strange really may be the way that things are shifting. And you want to be, you want to pay attention and you want to listen because you don't want to miss
and be on that cutting edge. Yeah, you want to be on that cutting edge and be
Yeah.
ahead of the wave. I train people all over the country in telebehavioral health. Dr. Rush Wilson and Dr. Harris and I, we do these trainings on a regular
Right.
basis. And there are people in our sessions who are completely lost, who I
Yes.
joke they're planning their retirements by the time we're halfway through the session because they're so overwhelmed with the amount of information that there is. And Ivy, I did want to mention to you, I will be doing a 5-hour learning institute before ACA next year, a learning institute for ACA on this topic for newbies, for new professionals who are trying to get into telebehavioral health. So that's something that ACA just asked me to do this morning, and I agreed I would be able to do it. So that'll be in New Orleans. If anybody's coming to New Orleans, definitely stop by and see that presentation as well. I'd love to have you there. All right. Well, I know we're getting close to time.
There.
Oh, good.
I'll be there.
Good. Well, the
Yeah.
so will I. ACA by a day. It's going to be on Thursdays this year. So.
Yeah.
And thank you all. You've been amazing.
Yes.
Such great presentations and participation. Just really have been amazing.
Yes. Thank you.
Thank you. It's very knowledgeable. Thank you.
And it looks like we have one more presentation coming up, self-care in the African American community.
Thank you so much.
Thank you.
Thank you.
Bye-bye.
Dr. Ellie.
Yes.
That was cool.
Yeah, that was very good.
Awesome.
Okay.
These presentations.
Yeah.
All right, Bianca, we'll see how many people we get to stick around for us as the last presentation on a Friday evening.
That's great. Awesome.
Hey, Bianca. Hey,
Hey,
Dr. Hudson
Jean.
again.
Hey. Oh, let me stop recording.